And everyone can hear me? Good. Back there? You have the thing? Oh, okay. All right. So let me. Okay. All right. Well, thanks everyone for being here. Actually, it's kind of weird. I cannot hear myself. uh, it's a pleasure to be here. I want to thank Joe Tauber for introducing me to the technology and Bright Membrane. Raj, Rusty, thank you for having me here. And I'm bringing a really nice tool for us corneal surgeons and beyond, and ophthalmologists as well. Kind of like a way that makes sense using the cornea on tissue to treat corneal diseases. And I'll go through that. So I'm very honored to introduce you BrightMEM, which is an allograft. This is the agenda. We'll do a little bit of introduction, the scientific background, which I think you'll find very interesting, and then of course the clinical data, the procedure video, and then I guess we'll have a chance to practice, right? So it's good to see old friends from North Carolina here, and thanks for coming. These are my disclosures. So basically, BrightMEM is it's a novel corneal allograft, really, and it's used to promote and regenerate ocular surface tissue, ocular surface disease. And it's really interesting. I mean, it's actually a mix of Decimus, right? It makes sense, actually, right? You have the right components that you need to protect the stroma, and what is very interesting, enhance the recruitment of limbal stem cells, and I'll go a little bit into that. What is actually very good, and I think a great point, is that in contrast to other therapies that you use to regenerate the ocular surface, this is transparent. So you can actually see beyond the membrane and make sure that the healing process or infections, or you can monitor exactly your endpoint through the membrane. Uh, it can be minimally manipulated. You see, this is not a DSEC. Pretty much it's the DSEC without the cells, and very easy to manipulate. It's not investigational, and it's available through Brighter Therapeutics. So again, once again, for having this product, it's very, very nice. It's a technology that came up from the University of Minnesota. So there's been a lot of thought put into this. For coding purposes, it's a CPT 65710, Anterior Keratoplasty. Basically, that's what you're doing. We're basically putting a lamellar tissue over the cornea, and it can be the tissue can be reversed through this code CPT V2785. And I can tell you, having done it in two institutions, at Duke and at Bascom Palmer, it's been very friendly user to order it and get reimbursed. I haven't had any problem with that. So what is this membrane for? Really the best way to think about it would be any patient that may have some ocular surface disease that you might be thinking doing either a superficial keratectomy or a patient that you need to rehabilitate the epithelium. Partial limbal deficiency, less than 75%, can be with or without epithelial defects. For non-healing epithelial defects, or therefore you have your Soster's patient with neurotrophic keratopathy. Postoperatively, I've used it in a lot of my high-risk corneal transplants that I want them to get rehabilitated fast to minimize rejection. Well, this is what I use instead of. I used to put amniotic membrane graft on these patients. Now I put this because I can see through, so I can actually monitor what is going on, and the patient can actually see. It's not that you're putting some obscure membrane that patients can't see through. And then, of course, that now that we go neurotrophic keratopathy, I don't think that the prevalence is higher, is that we are more aware of it. This is a very nice tool to have as only therapy or as an adjuvant to other medical grade growth factors therapies. And of course, for patients with toxicity, medicamentosa and contact lens, patients that you think we need to rehabilitate the corneal epithelium. This is what we have right now for patients that have limbal stem cell deficiency or persistent corneal epithelial defects. First of all, we eliminate the microenvironment, the insult, the medicamentosa, You take care of the leads, you take care of any scar tissue exposure, pretty much like an ocular surface reconstruction. You take care of the aqueous deficiency with lubricants or hematopoietic blood products, and then you restore kind of like a homeostasis so those epithelial cells feel comfortable and healthy. So as I already mentioned, these are the patients that we use amniotic membrane graft, or we do other forms of lamellar keratoplasty. And so basically, the way to think about this is kind of like putting a blanket actually over the corneal surface that is not only just a tissue to protect, but it's also a tissue that interact with the microenvironment of the epithelial cells, and you're bringing the limbus to the central cornea. And I'll give you an example of that. This is if you compare the bright membrane to the corneal epithelium, and you look at the markers that you see either in the central limbus or in the central cornea or the limbus. These are the markers that you see in the limbus. Of course, we're thinking about limbal stem cells. And if you look at the extracellular matrix that is present there, and you look at the bright membrane, they're very similar. In fact, identical. So there have been preclinical studies. I'll show you some of that data to demonstrate that these cells, the limbal stem cells, can be maintained and recruited or migrate through the epithelium. That this lasts, it does not get degraded, and it provides the source that we're looking for protection. I love this diagram because if you look at the limbal niche with all the markers, the best way to think about it, imagine that you can take the limbus and put it in the central cornea. And that's kind of like what we're doing with this bright membrane. You're creating that niche so cells and limbal stem cells can come and get established there. This is a great slide. This is a confocal microscopy demonstrated that you actually have the stratification across the membrane. These are limbal stem cells that are cultured, and you put them in the membrane, and what you can see here, the markers for stem cell nest with IBC G2 and K12, showing that there's actually a migration. And if you look with different markers, the ABCG and the P63, which is actually the marker for stem cell nest, you can see that cells, these are again primary limbal stem cells that are taken from the rim. You can see that cells that are having contact with the bright membrane have this stem cell phenotype, in contrast to cells that are not in contact with the membrane. Blue means it's staining for the cell. It's called DAPI. So you can see where the cells are, and you can see that these cells do not express any of the markers of stem cells. This is all in vitro study, and it's resistant to degradation. If you think of the somatocells, what do we have? I mean, it's actually Decimus, which is very resistant and prevents what we see is the bulging. So the group looked at degradation, and I found this data very interesting. If you compare this to multi-membrane graft, where you're looking in these diseases to have something that will stay as long as possible, and you do this what is called collagenase degradation assay. You put actually collagenase, incubate, and look at the presence or not presence or dissolution of the membrane. You can see that amniotic membrane graft by day 4 already have been actually by 8 hours already have been degraded, in contrast to the bright membrane that you continue to see it throughout time up to 24 hours. You can do this ex vivo as well in the corneal environment. So this is taking a cornea that has been you're going to protect for degradation. So it's kind of like in vivo degradation assay, ex vivo degradation assay, and you don't put any membrane. You can see by OCT and the clinical appearance over the globe what it looks like. But then if you put the amniotic membrane graft, you see degradation and not protection of the corneal stroma, which is the other really interesting thing about this membrane. Protects and prevent and helps or minimize or protects against degradation, as you can see how the endogenous metalloproteinases, if you will, of the cornea, this membrane does not get dissolved. So you can see all the big points. It's a bandage that works, that is clear, and has a biological interaction in the patient microenvironment. So let me go through some of the clinical data today. This is an 80-year-old patient with limbal stem cell deficiency. trabeculectomy, actomycin C, stem cells. This is what the cornea looks like. The patient also already had tried the non-standard therapies that we use, superficial keratectomy with an amniotic graft, SLED, for stem cell deficiency, and of course, all these patients eventually will develop corneal failure as well. So this patient underwent a DSEC, and it was very interesting. The patient said, I also want to take care of my little stem cells. How do we do that? Because I don't want to get a allograft either because I don't want to be under immunosuppression. So this was a solution. So this patient, after the DSEC, had a superficial keratectomy as well, and put the bright membrane, and this is what it looked like after surgery. And this is an example of what I told you. You can actually monitor what's happening below the membrane. You can see the DSEC, so that the surgery can actually follow and look at the corneal transplant as well. Another form of transplantation. So this is one of my patients, and so I pushed the envelope when Dr. Tauber told me about the technology. Of course, I pushed the envelope. How can I use it more? So this is a patient with graft versus host disease that had a melt and an emergent corneal transplant, and then developed this calcification or band keratopathy. It was really, really thick. And my options were, well, do I remove this and allow it to heal again? Or if it's too deep at the time of surgery, what happens if I need to do a corneal transplant? I want that corneal transplant to survive and don't get this form of band keratopathy. So this patient, I did a corneal transplant, and what I did, I put it right membrane. So what you see here is actually the corneal transplant, totally healed, and you can see through. It's very funny because, my fellow that was not with me in surgery, he put fluorescein, and he comes, Dr. Perez, the patient has 100% epithelial defect, and it's really round. And so I walk, no, that's a bright membrane. So the patient was actually looking at the bright membrane because, of course, it's going to take off the fluorescein. Very, very, very nice. So it's a potpourri of the clinical experiences. Over 115 back procedures have been done for limbal stem cell deficiency and persistent epithelial defect. And I think that list of diagnosis, now this is what I first think when I have to rehabilitate the ocular surface, actually. 100% of the cases been reported with complete repitalization, no failures, and up to now we have up to 18 months and more now of patients with follow-up after the transplant, after the use of the membrane. There have been no serious, tissue-related adverse effect. There has been interesting. These patients, their pain actually is decreased after surgery. Joe keeps asking me, can we do a patient with neuropathic pain? And I'm like, okay, I promise I'll wait for that. But actually, it's very interesting thought because you have this covering, and we're looking actually into that, how these actually interact or affect the corneal nerve by confocal microscopy. So hopefully next time we'll have more data on that. And as I said, this has been a very administrator and surgeon-friendly asset. It's reimbursed. You can order it. It's readily available. You have a good communication with the island that distribute them, and it's there for you. That's the only thing you have to think ahead when you're going to do the surgery that you need to order it. And of course, there's been no rejection because you just only have the membrane product fibronectin scaffold that I just mentioned to you. Very, very nice. This was my clinical experience. When we put this first slide, there were 6 cases. I think I have up to 15 or 18 cases. A lot of them with the same etiology. But as I said, I really pushed the envelope. So the cases that I did in this first series were patients with pemphigoid, graft versus host disease, chemical burns, and I was also not only trying. So my thought process on these cases that I was just doing a keratectomy, I was removing the symplepharon, I was reconstructing the pharynx. Why don't I put the bright membrane to allow cells to cover the ocular surface and attract whatever stem cells are left in these patients? And I was very impressed. Of course, the vision is not great in these patients because they had other morbidities, ocular morbidities. But I can tell you, as you can see here, a patient superficial keratectomy with corneal steroids. An ectodermal dysplasia patient. These patients barely have stem cells. This patient had complete wound healing. Patient with graft-versus-host disease, that's the one I just explained to you, described to you. Patient with OCP, again, I removed this ankylosing blepharon, and what I did, I just put the membrane over the epithelial defect and the rest of the cornea. And the neat thing about this is you can actually adjust the size. You'll see because you refine it. So I've done it even in cases that I have a small, patch graft with a melt, and I use the bright membrane to cover over that with with a derma punch, and I did like a 2 millimeter perforation and put it there, kind of like my wound healing tool for that area. And another patient, patient with partial stem cell deficiency. One of the things that I'm very excited as well, will be for the aniridic patient. We have these patients that have aniridia. At Duke we have a really big cohort of aniridic patients, and now in Miami as well. They follow me. I don't know why. But what happens, these are kids, or adults that are actually, their cornea slowly starting to get opaque because of the limbal stem cell deficiency. And even though they have, optic nerve and macular problems and nystagmus, you know, a loss of one line for these patients mean a lot. So you're always so tempted when you start having that haze over the cornea, and you're like, I really don't want to open Pandora's box. I'm going to scrape his epithelium or her epithelium, and these patients unfortunately lose that one line of vision because we're not as aggressive as a corneal surgeons, and these patients are not either that bad to get a keratolingual allograft. So this is a very nice solution. So these are patients and related patients. Then you can do a superficial keratectomy, and then you put the bright membrane, and the study it's going on, right? And I'm very excited to. In fact, now when there are a lot of new startup companies that are looking for growth factors, exosome things for the treatment of these patients. And when I meet with them, I can give them the example that there's actually a device, if you want to call it that way, that can help or can be complementary. So that doesn't exclude the use of other growth factors, which I strongly believe. So that's what I have in my vision. In fact, what I do with these patients, I use a lot of blood products, specifically plasma. So with the way I think about it, I tell patients, I'm going to make your stem cell niche happy. So I put them in plasma eye drops or serum tears, and after a month of therapy, then I do the superficial keratectomy, I put the bright membrane, and continue with the growth factor therapy. So I think it makes sense to me that you're trying to get these cells to heal better and better. This is the procedure. As you'll see, this is very easy. This is not a complex corneal transplant, lamellar dissection procedure. Uh, so this is, of course, courtesy of, is it Joe or Joe? Joe? Yeah. So this is the superficial keratectomy. Nothing different that you do. You can be as aggressive as you can and remove the scar tissue. In some of these patients, I also do burr to kind of create a more smooth ocular surface. Imagine that these cells are going to be marching over the cornea through the scaffold, or you're moving this limbus from the limbus to the central cornea. And you remove it, and this is what it comes with. It comes already labeled. It comes with trypan blue, so you be able to see it. Very similar to the corneal transplant. Without doing the corneal transplant, use a Trefine. Again, you can control the size. And this is 8 millimeters. I've used up to 9 millimeters, and as small as even 2 millimeters in patients. And then you just remove it. Again, this is like a dissect the other way, but without having the cells. And instead of putting it inside the eye, now what you do is you take the bottom. This is a very important step. You need to make sure that it's really, really dry. And believe me, this thing is going to stick to the cornea. And you pretty much put the bottom over the cornea, keep it dry. We usually wait at least a minute. And something new that I do now, in addition to maintain things really wet, really dry, I take a muscle hook and I kind of like put gentle pressure over it to make sure that we get good adhesion. And then you just remove it, and the membrane sticks there. This can be a tricky step sometimes, but don't worry. Even if the membrane comes off a little bit, you can manipulate, and it's strong. You're not going to break it. And in fact, Joe and I, we have played with it. We put it in the dish, and then we take it and try to put it back, and it doesn't break. So here you kind of uh, try to make it nice and level without folds. Again, you can be as aggressive as you can. Using the cannula is really nice, kind of like a LASIK flap that you can lift it up or you can actually smooth it. And because it has the pipe and blue, you can actually see it. Usually you have an S. It's the other way around, although I think we change it now. And so you know that the right side of the membrane is against the cornea. And then after uh, drying it, and again I wait at least 1 to 2 minutes, and then you'll glue it. You'll see uh, Joe will bring the fibrin glue, and it's very interesting. Uh, the easiest way actually is to put it in the edge. It doesn't matter if it goes over, but what we do now is make sure that you put it in the edge so that fibrin creates that seal. One case I actually put it underneath, and uh, I found I could learn quickly that you don't need to do that. Just put it in the edge. It's incredible. Look at here. And once you put it, then put a bandage contact lens and close the eye. And usually put these patients pretty much like my superficial keratectomy with an graph. It's like topical steroid 4 times a day, an antibiotic for 4 times a day for a week. And our experience is the people, depending on the stem cell deficiency status, but they would tend to heal pretty fast and without pain. So, so in summary, this is a very natural way to promote epithelial regeneration using the same tissue of the cornea, which is a very interesting concept. I love it. I think for me, it's optimizing limbal stem cell growth in vivo. It's optical clear. I cannot emphasize how important that is because as a corneal surgeon, I want to see what's open below the cornea. And also for the patient, we're doing this so patients can see. And when we do other procedures, their vision is not clear, and with that they are. As I demonstrated, it's durable, resistant to degradation, more than other alternative methods. And I think the preclinical data is pretty good, and in those limbal stem cell expansion. And in my laboratory, we also have a ex vivo expansion program. We're starting to work with the membrane to grow it over cells that we have genetically manipulated. And our hope is that this membrane can allow us to really grow them and put them easily back into the patient um, with the ability that the patients can see. And it's the preclinical data shows that it shows that protection and support the degradation. And the early clinical data I think is very compelling. With the endpoints of epithelial wound healing and ocular health, I think we're getting really good results. And again, I've been pushing the envelope in more severe cases, and we'll learn more. So thank you for your attention, and we have here to practice. Thank you. Should we do it? Here. Do you see it? Okay. Yeah. So this is excellent. So this is a cornea with RK. We're trying to hola. We're trying to protect it. So first of all, I mean, if it's a superficial keratectomy, you can get your beaver blade and do the keratectomy. As I said, I also like to supplement with a burr to make the corneal surface smooth. Remember, you're trying to get these stem cells to grow over it. So very nice. So good. Do we have the beaver blade, or should we just have they tried it before with the epithelium on?
Do you want a small, like
Yeah.
a little scalpel?
Yeah.
There's also a knife over there, but they have.
Oh, here it is. Good, good, good.
Yeah.
How are you? Actually, I found it.
We also have
No, this is not the.
okay,
No, this is a sweater. Yeah.
you know, on these Anterior guys, often the
Yeah.
heavy's already slept on.
Yeah, that's what I thought. But just to show, right, you're gonna. Yeah, there's no epithelium here, anyways. So that would you just have to follow the procedure and sharps, right?
Do you need that? Yeah.
No, we don't need
You're
it
done?
more.
Okay. I can grab it.
We'll put it here.
Just toss it anywhere.
As you can see, you know it comes pretty much like a corneal transplant, the same media and everything. A point to think. You know, when I do it, where's the focus? Oh, here. Yeah. A thought to think if you're doing it, you know, at the same time you're doing a corneal transplant, make sure the nurses know that they're two different tissues because, you know, for the container, it looks about the same, but you see it's very, very nice. And then in this case, we're going to do a 8 millimeter perforation. The Wetzel here. Again, the same thing you would do with a hand splint. You can see the S already there. So you can see the decipit, the membrane, the S. That's what's gonna now. Before they had it the other way around. Now that people want S, so when you put it, it's actually you're in the right orientation. And try to remove as much fluid as possible. Right? Just trying to clean it. Then you do a classic. You can see that's a nice example. You can see the membrane there. It's kind of like a dog. Again, you press very much like a single transplant. You can see it here. Make sure the rim is off. Okay. And again, even though you see the wrinkles there, it's okay. You'll be able to manipulate it and use it.
It's okay. It's actually kind of blocks my yeah.
Good. And again. I'll show it to you again. You can see the S. And again, even if you have folds, don't worry about it. We're gonna make it flat again when you put it in the cornea. Then you pick it.
Flipping it over.
And you put it over the cornea. Just, and then you let it sit. When we're in the real surgery, this is when you try to keep the field very dry so you get nice adherence. Here's where you know, you can use a muscle hook. Is what I have as well. Thanks for having the muscle hook, Joe. Can you see it? In fact, you can see the membrane already here. But a little bit longer. Dry it. No, these are the 0.12s. Yeah. And just remove it. You can see it. Tissue's gone. And again, you can manipulate it very nicely. You can see the S. So you know where you are in the cornea? That's it. And then you put the glue. We just put the glue around the edges. But you can see that I can touch it around and everything. It's not going to break. But you can take it and you can put it out and manipulate it very nicely. And then you put the contact
For
lens.
fun, crumple it up and do
Yeah. So here, you can do this.
as long as it touches one instrument. Even instead of
You can play around with it. So when you practice here, you can actually stretch it, moving around, very nice. I heard that there's a region. That's a thought. Can we put this in the sclera too as a complement?